So this is how my book starts. So the talk is going to really be two parts. One is going to be my story from the perspective of, again, having been in academic medicine for a long time and ending up not really being listened to by my peers. And again, I don't really blame anyone. My physician at the time was a good friend and a colleague at the medical school where I was at. But again, just misinformation and lack of knowledge. And so this was me, July 17th on a Friday, 2009, in the intensive care unit at UNC. And this is exactly what a surgeon told me. I've been around surgeons a long time, and when a surgeon comes in and you're in the ICU, after 12 years of severe cardiomyopathy of 10% ejection fraction, for those of you who know what that means, it's like having a 6-cylinder car driving on one cylinder. And the surgeon comes in and says, do you want me to sugarcoat this or just tell it like it is? So I just said, yeah, just tell it like it is. And this is what he said, you're going to be dead by Monday without a heart transplant. So the question is, how did I get there? I used to run Boston marathons. I was really the model of health. I ran 10 miles a day. Again, I played soccer and lacrosse at UNC in college. I had no family history of anything. I did all the right things, never smoked. Maybe I was a little too stressed at times over getting grants and getting papers into high-profile journals. And so we left Boston. So I was 37 years old, trained at Dana-Farber and at Harvard, so I was sort of in this, great space. My wife told me one particularly bad winter that she never wanted to see a snowflake again. So I took a job at the University of Miami where there wasn't any snow. And literally within weeks of moving to South Florida, began to experience what for me were very strange symptoms. So palpitations out of the blue, my heart would start racing to 200 beats a minute, never for more than 45 seconds or a minute at most. I had an episode of several weeks of brain fog, which probably a lot of people here will relate to, but I tell my colleagues it was like taking 50 milligrams of Benadryl every 2 hours. And I was attending on a bone marrow transplant unit with really sick people, running a lab. And I went from running 10 miles a day to barely being able to walk 10 yards from lack of fatigue. Now, I'm an oncologist. I still go to clinic a day a week, and actually yesterday morning was a busy clinic. And so I hear a lot of our patients, or my patients, telling me, that they feel fatigued. And I think there's from what you've experienced fatigue, what I experienced, and what my patients experience, is a lot different than when you tell somebody out in the real world, gee, I'm fatigued, because to them that may mean, I don't feel like running 10 miles a day, I feel like just watching a football game today. But profound fatigue is a real illness, is a real symptom of something going on. When you run 10 miles a day and you can't walk 10 yards without having to stop, not for shortness of breath, but just for feeling like you have no ATP molecules in your body, that's, to me, not stress. And I just had all sorts of aches and pains and joint pains and muscle pains. And so I had an extensive workup. This is a test I hope no one ever has. It's like some incredibly barbaric test. It's one of those things that 50 years from now, hopefully they'll look back and say, why did anyone ever give a tilt test to anybody? So if you've had it, they strap you to this table. It's got, some spiritual significance. They strap you. There's a whole bunch of people with notepads looking around, and then they tilt you straight up. So you're laying flat, they tilt you straight up, all the blood drains from your body, and they're all looking at you. Do you feel dizzy? Do you feel dizzy? You going to pass out yet? And they're actually looking for, in this case, they were looking for something called neurogenic syncope, which is this dysregulation of the receptors on the heart that respond to adrenaline. And so rather than having a normal response, your heart slows, you pass out. And one of the treatments for that is to give a beta blocker, which seems a little contradictory if your heart slows. But anyway, so I had this extensive workup. The only thing that really was abnormal at that time, they did the usual blood counts, chemistries, liver function tests, was this what we call an abnormal SPEP, serum protein electrophoresis. Now, I'm a hematologist and oncologist. That essentially measures protein in your blood. And for an oncologist, what we look for in people who have cancer is what we call a monoclonal spike, which is an antibody being produced generally by a cancer cell. So it's sort of like the daughter cells of a mother cancer cell. But it's one type of antibody that generally indicates multiple myeloma. So I had an abnormal serum protein electrophoresis, but it wasn't monoclonal. Now my doctor, who was an internist, was telling me, I think you have multiple myeloma. He's telling me I'm a hematologist. I said, well, this is polyclonal. I mean, my body is responding to something by just producing antibodies. It's not a cancer cell. It's responding to something that's happening in my body. I also had an antibody test that actually Alan Steer reported on very early in his work in Lyme disease called an anti-cardiolipin antibody, an IgM, which was elevated, and that actually he showed was elevated with fair frequency in people with Lyme disease. Now, remember, I was living in Florida at the time. Lyme disease was like 1,000th out of the top 10. And so I kept telling people, you know, I'd been in the Cape, I used to run in the woods, but they didn't even know what Lyme disease was. So I had all these tests. I had an abnormal tilt test, and they said, oh, okay, now we understand why you're feeling weird. You've got neurogenic syncope. Now they put me on a beta blocker, and the first pill I took, my heart rate slowed to 30 because I was probably at that time having heart conduction defects from the Lyme disease. And I just stopped the drug myself. So this, again, was going on for about 4 years. And every time I'd go to the emergency room, the tachycardia would have resolved. They'd do an EKG, and they'd say, you look fine, you're stressed. You look fine, you're going to work, right? You got a lab, you got, you know, your wife, everything. You don't look sick. So, you know, you're an oncologist. So, so this went on, and then in the spring of 1997, for the first time in the course of the disease, I developed frank arthritis. I mean, swollen joints out of the blue, couldn't hold utensils, wrists, knees, everything swollen. And it just so happened that I was prescribed doxycycline for a completely independent reason. And within 24 hours of taking the doxycycline, the arthritis resolved 100%. And so here's a good one. So I call, this is a fatal mistake, I called the big centers in the Northeast, and I said, I think I have Lyme disease. And I get connected with the Lyme disease clinic. I won't name the centers, but I'm sure everyone knows they're in New England. Some of them are in the Ivy Leagues, some of them are not. And to a T, all of them said, you don't have Lyme disease because that's just a non-specific anti-inflammatory effect of cyclins, of that class of antibiotics, which there is some anti-inflammatory effect, but as a friend of mine, I don't know if Steve Phillips is here, but as he said, go break somebody's femur and tell them to take some tetracycline and see if that helps with their pain. You know, so that was the thing. So in the spring, I then progressed. So all along, I was having these cardiac manifestations, these arrhythmias. And actually, for about 2 years before, so about 1995 to 97, I was having more progressive, what turned out to be heart block. So I was having, you know, this first degree, second degree, and third degree is the most extreme. And so I started having what they called Wenke-Bach syndrome, which is second degree heart block, which actually is pretty significant. And I remember going for a stress test at a cardiologist who was pretty famous for arrhythmias. And he said, you know, I don't know what's going on with you. Right now, I'd say your response to exercise is normal, but I have a feeling at some point in the future you're going to require a pacemaker. So just keep exercising, and when you require a pacemaker, you'll require a pacemaker. Not very reassuring. So June of 1997 was really the pivotal time. So not only did I have this episode with doxycycline that responded, now I'm really thinking this has to be Lyme disease. But I also start having new symptoms where I'm waking up in the middle of the night with this exploding white light, which turns out to be that my heart, there were 6 seconds in between beats. So 6-second pauses where my brain was not getting any oxygen. That's like an eternity for your body not to get oxygen, especially your brain. Fortunately, I don't know if any of you have ever driven down I-95 in Dade County. None of this happened during the day. Otherwise, it would have been a tragedy. I mean, it's a tragedy driving there anyway, but it would have been even worse. So I was having these flashing white lights, the palpitations, and then I start noticing that my heart rate is about 38 to 40 beats a minute. Now, if you're Bjorn Borg back in the days and you're the best athlete in the world, or you're a marathon runner, which I used to be, but I wasn't at this point, I could barely walk, 5 feet, a heart rate of 40 would indicate that you're in incredible condition. A heart rate of 40 for me was not normal. And I was working full-time, taking care of patients, writing grants, running a lab. So I go into the hospital, and I remember, now they've got smart EKGs. You don't even need a cardiologist because the machine tells you right there what you have. So I remember sitting on the table, I'm looking over at the machine, and it says complete heart block with ventricular tachycardia. Now, ventricular tachycardia, for those who don't know, is one of the most common causes of sudden death in people outside a hospital setting, because it degenerates from what we call VTAC to ventricular fibrillation, and unless you've got a defibrillator right there, you're probably not going to survive. So I was having, my rhythm strip was tacked to the wall of the cardiology fellow's office, which is something you never want to have. It was a real instructional tool. All you fellows, if you want to see every arrhythmia you never want to have, go check out Neil Spector's Holter monitor in the office. So I was instant fame for having every bad arrhythmia. And I had lost about 20 pounds. Now, I was never heavy to begin with, and so, something clearly systemically was going on, and I don't know that anyone at this point would say that's just stress. So I had a workup, and in fact, since I didn't trust anyone in Miami, I had my blood test sent again to a hospital that I thought was reputable in the Northeast, thinking they'll get it right. I obviously have to have Lyme disease. And my cardiologist was waiting to put the pacemaker in, waiting for the test, because there was either going to be a pacemaker or I was, hopefully going to get the right antibiotics. And so 72 hours later, my cardiologist calls me and said, I got bad news for you, your test is negative. Now, when a cardiologist says your test is negative and you send it to a place that you think is reputable because they've got the name, I figure it's a negative test. So I didn't really even ask anything at the time. And I didn't know much about the controversy over Lyme disease, in 1997. And so it turns out that it really wasn't negative. And in fact, probably like a lot of people in this room, it was very high titers. I mean, the serum protein electrophoresis spike that I told you about earlier was from the level of the IgM antibody from the Lyme test. But they didn't believe that, so this is the diagnosis I was given, idiopathic cardiac conduction defect. Now, I gave a TED talk in Nashville a year ago, and I tell people what idiopathic a friend of mine reminded me, it stands for idiot doctor, pathetic patient, right? Because God forbid you get a diagnosis of idiopathic, you're probably not going to do all that well. So you never want to have that diagnosis. So instead of getting antibiotics, I had a pacemaker defibrillator put in that I had for 12 years. I moved to North Carolina in 1998. I was starting to exercise again, not much, and I went to a cardiologist to see how much I could exercise. Got an echocardiogram 24 hours after I had the echo. She called me and said, is there a chair nearby? I'm an oncologist. I generally know what that means. And she said, you've got 10% ejection fraction. You need a heart transplant immediately. So let me just take one step back. So I had the pacemaker. When I had the pacemaker put in, this very famous cardiologist who was part of the dream, I don't know if you remember the dream team, Reggie Lewis in Boston was a Celtic, he had an arrhythmia. So the cardiologist I went to as part of the dream team, they were from Boston, Miami. He was one of the ones who said Reggie Lewis should never play basketball again. He told me, we're going to put the pacemaker in, you're going to feel great, Neil, because your heart rate will be 70, you won't feel symptomatic anymore, you're going to feel great, even though you have an idiopathic condition. So I didn't feel great. I went back to him a month later to have the pacemaker checked, and I said, I don't feel great. And this is exactly what he told me, a colleague of mine. I mean, I'm at faculty at the same medical school. He said, denial is the most common reaction of someone your age when confronted with heart disease. I never saw him again. And I tell patients, if anyone, I don't care if they got a diploma from Harvard, Yale, wherever, anyone ever tells you that, you need to get a new doctor. If anyone ever tells you this never happens, you need to get a new doctor. Because anyone who thinks they understand human biology to that degree should get out of medicine. So the end of the beginning, just some things that I've learned for myself that I used to tell my patients, which is trust your instincts, be your own advocate. This medical system, if you're not advocating for yourself, you're screwed, right? It is so complex. It is so virtual. You're lucky if your doctor looks at you now, because they're typing away because of the electronic medical records. They got to get you a copy. And some of them don't even lay hands on you. It's all about the labs, lousy labs, scans. No one even looks at you. No one knows yourself better than you. And unfortunately, I was able, because I knew the jargon, so I could describe what was going on. But if you go in, you say, yeah, I got a little pain in my left tooth here, and blah, blah, blah. Your doctor's already thinking about the next patient. So, you have to advocate. You have to be prepared when you go to see a physician nowadays. So I stayed alive for 11 years with 10% ejection fraction. And the only people who really knew how sick I could have been or was, because I could have died at any moment with that ejection fraction and having all throughout that 11 years ventricular tachycardia almost all the time. And getting shocked multiple times, which is something in the book you could read about I would not wish on my worst enemy. So how did I do this? I exercised a lot, probably more than most people with normal ejection fractions, 45 minutes, 60 minutes a day, 6 days a week. I don't advocate for a lot of supplements, only probably because I don't know enough about them. But I'll tell you the one that I took lots of was ubiquinol or CoQ10. Stress reduction. I give talks on the role of stress in promoting metastatic cancer. There's great scientific data to support that and how mind-body is really critical. And certainly for anyone with a chronic illness, to me, CoQ10 or ubiquinol and this are important. And I used to tell my patients this too, I did not let my disease define my life. I lived life to its fullest. Fortunate to develop 2 cancer drugs, coached my daughter's soccer teams along the way, got shocked a few times doing stupid things like running up and down a field in 105-degree heat without drinking too much water. Traveled the world, continued my research. There I was coaching soccer teams. Here I was about 3 months before my transplant, so I certainly wasn't just stuck in bed. That was me a month before my transplant at my wife's graduation for a PhD. And I reprioritized my life. Now, I always tell people if I get a little emotional, it's because I have a female heart. So that and dark chocolate. Anyone have any dark chocolate? I developed a craving for dark chocolate. So I reprioritized my life. I used to let experimental results really get to me, like, we didn't get what we thought. It still happens to some degree, but not nearly as much. I used to get very upset over bad reviews on manuscripts. It doesn't bother me all that much anymore. Grants still bother me a little because my salary comes from grants, so I wish I could say it doesn't bother me, but it does to some degree. Although if somebody told me I had to work at Whole Foods, it would be fine with me. What really was tough, and I would tell anyone to do this as an exercise, whether you think you're healthy, whether whatever's going on in your life, was literally writing a letter, what I thought could be my last letter to my then 11-year-old daughter at the time, when I was going in for transplant. And the other thing I would say is you have to have somebody who's strong and rational who can counteract the doubt and anxiety. My wife, who's in the medical profession as well, was pretty amazing. And if anyone needs a surrogate helper, I'll rent my wife out to you. She's tremendous. The simple things in life are great. So I hadn't had a shower in like a long time, and in walks this guy, like 2 days after my transplant, and says, "You want me to wash your hair and give you a trim?" That was like the greatest experience of the transplant. Okay, now I'm going to end on, I think, what I like to talk about, which are the biological analogies between cancer and Borrelia and probably other co-infections, although it's just going to be Borrelia listed here, and how we can learn. We don't have to reinvent the wheel for research, and how we could take this field forward. And one of the areas that I think is bringing people under the tent who are not card-carrying Lyme disease researchers. There's a lot in immunology, there's a lot in cancer research, as I'll show you, that's very relevant. And as we're doing, and hopefully we're going to get this grant funded, a large grant, We're doing just that. We're bringing people in from cancer research who look at this field and say, this is crap. I mean, literally. I can't believe in 2017 this is the state of Lyme disease research from the academic research. There's plenty of other things that are going on. And by the way, the really good papers are done by veterinary schools. The vets are doing the best research. So when someone asks a question about why aren't the good papers being published, I read the veterinary literature. It's amazing. Okay, so here, this has nothing to do with the election because I'm not sure who would get this type of thing here. But it essentially is my way of saying that I've been in medicine a long time. I've never seen a divide like there is with that type of rhetoric about anti-science and blah, blah, blah. I mean, this is quite unique, in my opinion. And we really do need to bring people together, multidisciplinary people from outside the field, bring them in, clinical, basic, translational, and I think very importantly, people in this room, real-world experience. You know, not just some ivory tower person, but people who are treating patients and have a tremendous wealth of experience and understanding about the biology. Okay, cancer treatment. So again, I'm going to go back and forth. What we've learned in cancer. Pre-1990s, this was it. Chemotherapy, radiation, surgery. It was pretty slash and burn, you know, no pain, no gain. You name the motto, that was the way we treated. 1990s, what happened? So again, back here, this is all chemotherapy, radiation. 1990s, all of a sudden, this wealth of information, like where's, you know, Nixon's war on cancer, where's all that basic research? When is it finally going to hit the clinic? Well, this is when it started to hit the clinic. Targeted therapies like Gleevec, which transformed the treatment of chronic myeloid leukemia and was based on targeting a genetic mutation in cancer. First monoclonal antibodies, Herceptin for HER2, an area that I spent a lot of time working on. And now all of these molecular profile, genome sequencing, you know, every patient who comes in now with cancer gets their tumor sequenced, looking for mutations, looking for precision medicine. What mutation can be targeted with targeted therapies that target the cancer but not normal cells? You don't have to memorize this. There may be a quiz at the end. But this is really, you know, cancer is like this room, right? There are lights, there's switches, there's wiring throughout the whole wall. The name of the game is to turn the lights out. Some cancers are pretty easy. There's one switch, you flip the switch off, all the lights go out. Most cancers, like breast, lung, colon, are more complicated because there's multiple switches, there's multiple wiring. You have to figure out what are the wires and what are the appropriate switches to turn the lights out. I don't think these infections are that much different. But all of this information and recognition that cancers have addictions to certain pathways. They're addicted to sugar, right? They have a whole different metabolic requirement than normal cells. We can take advantage of that. I'm going to show you some data, again, in work that we're doing in cancer, but work that we want to use to inform what we should be doing differently in Lyme disease. I personally don't think we should be screening for more antibiotics, more and more antibiotics. That's not the answer, again, in my opinion. I think we need to be smarter, and I'll show you how we could do that. So here's all these pathways cancers are addicted to. Again, how do they avoid the immune system? Inflammation, tumor-promoting inflammation. When I was in medical school, inflammation was good. You have inflammation around a cancer, that's good. Your body's trying to react to it. Now we know that's not good because the inflammation is feeding cancer growth and metastatic dissemination. Inflammation in the body is not good if you have a cancer cell sitting there somewhere. And to be honest, most of us right now have cancer cells that fortunately our immune system is taking care of. I can tell you a story. Kids who went to a pediatrician for a middle ear infection, a third of them had a molecular marker for chronic myeloid. They had the Philadelphia chromosome. Now that doesn't mean they had CML or they were going to develop CML. It means that we all have mutations going on in our body, just that our body can handle it unless your immune system is not functioning properly. This paper really changed the landscape. So all of that information and this has completely changed the way we view cancer. And I would submit this is where we need to go in Lyme disease. So this paper came out by a friend of mine, Chuck Peru, at UNC. It essentially showed that breast cancer is not breast cancer is not breast cancer. You can't tell a woman, I don't even know what breast cancer means anymore. There's like 25 different subtypes of breast cancer. And so this shows, and this red and green, these are just genes, the expression of genes. It just shows there are different, here there's about 5 different, now we know there's more, subtypes of breast cancer. They should be treated differently. You can't treat this breast cancer with these red genes like this one with green, okay? It's not one size fits all. And now we've learned how to unleash the immune system, right? We were just talking, I mean, this is known, this isn't HIPAA, but Jimmy Carter had metastatic melanoma. He's the poster child for immunotherapy. He had brain mets and liver mets, and now he's in complete remission without chemotherapy. Why? Because we have figured out how tumor cells evade the immune system, and now we have therapies to essentially take the brakes off the immune system. Tumor cells have usurped the body's, when you get an infection, your body responds, but then you have to shut that inflammation down or you're going to have autoimmunity. So the body has a normal feedback that shuts off the immune response. Now, cancer cells have hijacked the shutting off of the immune system. And so for years, the holy grail was, why doesn't your immune system recognize a cancer? And here's part of it, because they're what we call checkpoints. And cancer cells have taken the checkpoints to their advantage. And so your immune system is not activated in the presence of cancer cells because of these checkpoints. Now we've got antibodies to block the checkpoints. They're called checkpoint inhibitors. Now in 50% of people with metastatic melanoma who would have been dead 5 years ago, 50% of people are essentially probably being cured. 25%, I never thought I would tell a patient with metastatic lung cancer that there's a chance they could be cured. Now about 25%. I wish it were 80 or 90 or 100. But 25% are cured without chemotherapy, just by activating the immune system. I'll tell you, there's good rationale for why Borrelia and other infections, and actually there's data with other chronic infections, leishmaniasis, that these infectious pathogens utilize the same checkpoints that cancer cells do. We should be testing this. This is known. This isn't reinventing the wheel. All of this is just, there's like 5 pages. These are all the targeted therapies that are available for cancer. Now, I'm not telling you we've cured cancer. It's not mission accomplished. But we've come along, none of these are chemotherapy. They're all targeted therapies, antibodies, oral pills. This is the possibility of understanding the molecular biology of your target, cancer, Borrelia. This is a drug I worked on for HER2 breast cancer. This is a woman who had what we call inflammatory breast cancer. It is the worst type of breast cancer. This is like a 3rd-degree burn. This went all the way down her back and was eroding into her lungs, into her chest cavity. Some of these women don't make it to their next appointment. Almost all these women have lymph node involvement, and a third have metastatic disease at the time they're initially seen in a doctor's office. So she was about to go to hospice care. She was on a morphine drip here. This was incredibly painful. And you could see it's at a site, it's a recurrent, where she had a mastectomy. And within 2 weeks, it was almost completely gone, and she was out playing golf. That's like the magic. It's not magic, it's science. That's the beauty of doing targeted therapy. Not just giving chemotherapy to blast your kidneys, your bone marrow, and everything else, but to being smart about it and saying, what is driving this cancer? Well, what's driving this cancer is a light switch called HER2. And we could target HER2, and we could shut the lights out in that tumor. So when I go and I listen to people at Hopkins and the MGH, and I'm not here to get political about things, I never hear people talking about what's already known. This is what's known. This was published in 1997, the genome for one of the species, for one of the strains of Borrelia. So here's all the pathways that are known. And yet we're still developing antibiotic therapies. And I just told you in cancer, we got away from just developing. I'd make the analogy that antibiotics to me are almost like chemotherapy. They're indiscriminate. Take antibiotics, you feel pretty crappy, right? They're not really selective just for the bacteria, and they kill normal bacteria too. You get C. diff. So why aren't we developing targeted therapies? Why don't I hear anybody talking about, I mean, some people are, but this has really gone unnoticed. And these are known for Bartonella. This isn't like any great surprise. That was published in a top-tier Nature journal. So I'm going to just say this. Here's some analogies that I make between cancer. Some that are common, some that, cancer is not, you don't say cancer anymore. It's not one disease. It's thousands of, when people say to me, why haven't we cured cancer? I tell them which one. It's thousands of diseases. Yet we still talk about Lyme disease as if it's one disease, as if everyone in this room, if they had Lyme disease, has exactly the same disease, same symptoms, same strain, same co-infections. This is baloney, right? We'd be in the dark ages in cancer if we still viewed cancer the way people talk about Lyme disease. We now have a personalized approach to cancer treatment. People have their tumors sequenced. People have their blood sequenced because we know that tumors shed DNA into the blood. I remember a few years ago, people said, you will never be able to detect tumor DNA in blood. Okay, well, we do it now. Hopefully, we're going to hear some interesting and exciting things going on in detection for Lyme disease. We know it's difficult, but so are a lot of things. We have technology that can overcome that. Early versus late. You always want to diagnose, well, you want to prevent, number one. But if you catch breast cancer in the DCIS stage, that's curable. Early versus late. I don't know why anyone would think that Lyme disease or any co-infection that is 10 years into the making is going to be easy. Every paper I read and all of the experts talk about, you got a rash, we treated you immediately. Well, what about the people who are 5, 10 years, 15 years into the treatment? Why do we expect giving 4 weeks of doxycycline and another 4 weeks is going to be the magic bullet? We know that the relative of this, syphilis and other spirochete, when it gets to tertiary stages, the damage is done. You have tabes dorsalis, dementia, whatever from syphilis, you're not coming back. I might add also, because some of you may wonder, when I got treated with intravenous antibiotics. The first dose of ceftriaxone I had the worst Herxheimer reaction. My wife was ready to call 911. I was rigering, shaking. We weren't sure whether I was having an anaphylactic reaction or not. All my symptoms improved, except the damage to the heart was permanent. I had biopsies. Unfortunately, they didn't look and do special stains, but I had fibrotic changes in the conduction system of the heart and other things. So, for some people, maybe sadly, things may not be easily reversible. So early treatment, and I think early effective treatment. Resistance, I spent the greater part of my career studying molecular mechanisms of resistance to targeted therapy. I don't know why anyone still denies things like persisters. Even the people at Hopkins published the word persisters, and yet I was talking to somebody on the West Coast at a big institution, and they're banned from using the word persisters. And yet actually they want to set up a big Lyme disease institute, which I find sort of interesting. So anyway, no great shakes here. We've known about this. Morphology, we hear a lot about the changes in shape of the bacteria, from the corkscrew to circular forms. We've known about this, again, in cancer for a long time. I'll show you some of that. It's called EMT, epithelial to mesenchymal transition. There are proteins on the surface of tumor cells that spit out chemotherapy. That's one mechanism of resistance. The same proteins are on Borrelia. It's identified in that genome I showed you. They spit out antibiotics. So why would you give somebody antibiotics? Maybe that bacteria is just spitting it out as quickly as you put it in. Again, all of this has been known for 15, 20 years in cancer. We need to apply the lessons here to Lyme disease. We don't need to start from scratch. It's already here. It's right here. Tumor microenvironment. We know that when I trained, it was bad seed, normal soil. You got a bad breast cancer, but the breast is normal. We know the breast, where breast cancer develops, is not normal, right? The tissue that looks normal under the microscope, it's not so normal. And so now we're actually trying to understand how do we target the microenvironment and not just the tumor. Same, and there are experts who are going to talk later about biofilms. We know that there's a microenvironment around these bacteria. It's not just the bacteria, it's what they do to the tissue that they invade. Homing. Metastatic dissemination is not bad luck. We now know that why some women with breast cancer get brain metastases and others get lung. There is science and rationale to it, and people are trying to develop therapies to block that. And I'll show you data, again, from the literature from outstanding veterinary schools. We're not talking, the Guadalajara, not that there's anything wrong with Guadalajara, but we're talking about UC Davis, top vet schools that are doing amazing research, showing that why someone like me may have got cardiac manifestations and no rash and very little other joint problems until late, why mine were primarily cardiac. That probably wasn't just bad luck or bad karma. There's science behind that. So there's tissue homing, some bacteria home to heart, some to joints, some to other tissues. Preferred energy, we know that cancer cells are addicted to sugar. We know that Borrelia is addicted to sugar, inflammation. So there are 16 million cancer survivors. Many of them have long-term cognitive impairment. That's a huge area now of study. And certainly a lot of what we're learning about cognitive dysfunction, I think we can apply to why people get cognitive dysfunction with these infections. So I don't want to belabor this, but this is just to show that nothing in life is easy. So this is sort of an encapsulation of 15 years' work, looking at multiple mechanisms of therapeutic resistance to HER2-targeted therapies. And again, this isn't just research for the sake of publishing in nice journals. It's research that has led to new treatments. So here's work that we did identifying the estrogen receptor causes resistance to HER2-targeted therapies. It turned out that when we turned the lights out, that one of the switches suddenly came on and turned the lights out in here, and it was the estrogen receptor, which was never active in these tumors until we blocked HER2 signaling. Anyway, it led to an FDA approval of giving an aromatase inhibitor plus a HER2-targeted therapy. So smart science not only makes for great papers and grants, it changes people's lives. Okay, cancer cells, epithelial to mesenchymal transition. This is what a cancer cell looks like in the breast or the prostate or the colon. This is what happens when it tries to get out and into the bloodstream or the lymphatics and becomes more metastatic. It changes its shape, just like these bacteria. And when it changes its shape, it changes the protein targets. So these here in brown or yellow are different than the green. Now, if you wanted to target these cells that are metastatic, you can't be targeting this. You've got to understand the difference in the molecular biology of these cells and where they are in their genesis, right? These are sitting in the breast, in the case of breast cancer, prostate. These are ones that have gotten into the lung, the liver, the brain. You need to understand this. And again, there are people who are much better versed, and we'll talk about this, but these bacteria change shape. And when they change shape, we need to understand what the protein targets are expressed in this shape versus this shape. We need to be really smart and personalize this treatment. It's not a one-size-fits-all mentality. Again, Lyme disease is not just Lyme disease. It's a very complex mix, just like cancer is. This is the reductionist view. Oh, it's all these bad tumor cells. This is the reality. It's tumor cells with bad blood vessels, with bad fibroblasts that are feeding tumor cells. Very analogous to what I think we're learning about the microenvironment around these bacteria. It's not just the bacteria, it's the other things that are created to support the bacterial infection. Inflammation is bad, okay? This is looking at genes. The red means they're upregulated, the green means they're downregulated. These are breast cancers that were sensitive to this HER2-targeted therapy. These are some that are resistant. You could see different patterns in the sensitive and the resistant. And it turns out that what makes these breast cancers resistant, one of the reasons, is inflammation. And what do we know about Borrelia and co-infections? Lots of inflammation, right? And that's not good for cancer. It's not good for your infection. But again, this is very analogous to cancer, right? The bacteria usurp the microenvironment to their advantage, to evade antibiotics, to evade the immune system, to do a lot of things. And so, and I know there are people targeting biofilms and developing therapies against biofilms. Again, we need to be very smart about doing this. This is just showing that cancer is not random. Some cancers go to the lung because there are homing. I mean, the cancers are told, stop in the lung, stop in the brain. It's all pre-programmed. Same thing. This is, again, work from veterinary programs showing that there are proteins on the bacteria that you could identify that are more likely to end up in your heart or your joints. So if we could start doing the molecular biology and predict who's going to end up with cardiac and others, we could be smarter about the way we treat this and not just do one antibiotic fits all. And I'm not saying there's anything That's the state of affairs now. We need to change that. Cognitive dysfunction, there's lots of reasons why cancer patients get this, blood-brain barrier changes, cytokines, inflammatory cytokines upregulated, all sorts of things, hormone changes. We know all this goes on too with chronic infection. And so there's a lot to be learned. I want to end on some work that we're going to be doing. So maybe next year or the year after when I come back, if I come back, we're going to have some, I think we're going to, I don't want to sound like somebody in the public light. We're going to have some really, really amazing work. No, I think we are. So we actually have, as I said, we've brought in people that I know who are in cancer research who've done phenomenal work, basic scientists. And I went to them and I said, we've got to change the Lyme disease world. You know, I've been in cancer research for 25 years. Maybe one less cancer researcher is okay because there's 5 million in the US. But I think there's a real need to do something different in Lyme disease. And so this is a part of our proteins. We call it it's the purinome. It's essentially, and I'll tell you why we're going to do this. We are looking for targets in these bacteria, and we're trying to get different strains because there may be differences between strains. And we're starting with Borrelia and Bartonella. And not that this couldn't be done for Babesia, but just to really focus in on those two infections. And we're looking at this part of the proteome, which is about 80% of the druggable targets in our proteins and in these bacterial proteins. And these are very important. These regulate metabolic pathways in bacteria as well as normal cells. They regulate DNA repair. They regulate survival. And so we've utilized this technology to identify drugs against the purine-binding proteome. And I just want to show you this. I'll make quick biologists out of you here. So this is looking at the cell cycle. These are cancer cells, again, but I want to show you how this technology is potentially doing something amazing in cancer, and we want to do the same to discover new drugs for Borrelia and Bartonella. So this is a cancer, this is what's called the cell cycle, and this is what a normal one looks like. So DMSO is a control. These are cells, again, normally in G0, G1, the different phases of the cell cycle. They're either quiet cells, they're growing cells, they're replicating DNA. So we give an inhibitor of what we think is a survival pathway to these breast cancer cells. It doesn't look all that much different. Okay, so I want you to focus on this M1 area. These are cells that are undergoing what we call apoptosis, or cell death. This is a normal programmed cell death. The body, rather than just exploding cells, essentially kills cells in a very programmed, lovely way so you don't release toxins all over the body. So I want you to look at that space. Okay, so in the normal cells, in the normal conditions, there's less than 1% are undergoing apoptosis. We give this inhibitor, again, developed at Duke in collaboration with someone in pharmacology, using the technology that we're going to leverage now for Borrelia and Bartonella. And we don't really see much. There's now 2%. We give an inhibitor of a metabolic pathway that tumor cells are addicted to alone, and we see about 21% apoptosis or cell death. Now look what happens when we're smart, and we realize that when you give this inhibitor, it causes a reaction that now makes this target, this molecule, much more relevant. When we combine the two, we see 97% cell death. This is actually going into women, this combination, this based on some of these studies and animal studies. It's smart, rational drug development. It's approaching things scientifically and not just pulling everything off the shelf. So this is what we're going to do. And we've already done it, even without the money yet, but hopefully the money and the contract will be signed soon. We've looked at the purinome in Borrelia, just like we did in cancer, and developed those targeted therapies. And what we see are there's about 130 targets that are druggable. These are not antibiotic targets. These are targeted therapies, just like I showed you for cancer. 130. And they're in all parts of the bacteria. And again, we'd love to know whether they're different in the corkscrew spirochete versus other shapes, because we need to know that. And we've already narrowed that down to about 30 that look like they're highly specific for Borrelia, and we need to get Bartonella. There's Amanda. We need to get Bartonella, and we need to start looking at Bartonella. But we've narrowed it down to about 30 that don't look like they cross-react with E. coli or normal bacteria, which would be great, right? We want to develop a targeted therapy that doesn't wipe your gut flora out, because now we know that the microbiome in the gut regulates everything in your body. So we want to avoid that. Now, I'm going to tell you something I think is incredibly exciting, and this is going into the clinic in cancer, and I'm going to tell you when we develop small molecules against some of these targets in Borrelia, we're going to do the same thing. We want to develop a theranostic, a therapeutic diagnostic in one molecule. And so we want to develop the small molecules, the drugs, that will target Borrelia and Bartonella, and then develop a non-invasive imaging modality that will unequivocally say, if that area lights up, if you come in with arrhythmias and your heart lights up with one of those probes, that it's not nonspecific. It's not like a PET scan or a SPECT scan, which tells you there's an abnormality, but doesn't tell you what the abnormality is caused from. It'll tell you that it's Borrelia because this small molecule that's carrying the imaging reagent is directed against Borrelia. And then we could use the same small molecule as a treatment, so a theranostic. And I'm going to show you how it's working in cancer. So we developed a molecule, a small molecule, against what's called heat shock protein 90. This is upregulated on a lot of cancers and not normal cells. So this is a small molecule. This is a drug targeting HSP90 on cancer cells but not normal cells. And when we inject this with an infrared dye that can be imaged, what you see is that the dye is taken up in the cancer but not the normal. There's actually a gland behind the eye that humans don't have. And it lasts there for about 24 hours. And so and there's a lot of other studies, I'm just showing you some. And we could do this with very minimal cells. So we can inject as few as 10,000 tumor cells, and it still lights up. If you did a CT or an MRI with 100,000 cells, and you're a woman with breast cancer, you'd be told you have no cancer. This is minimal disease that is undetectable by current imaging modalities, and we could pick this up with this highly specific targeted therapy. Now imagine if we could do this with Borrelia and Bartonella. So anyway, so I want to end, and so that's our plan. So we have targets. We're going to start screening chemical libraries. Again, these are not antibiotics. These are targeted therapies. Just like that woman with inflammatory breast cancer was a targeted therapy. That was not chemotherapy. That was a smart drug. We want to develop smart drugs for these bacteria. We may have to combine them. Maybe we'll combine them with a biofilm buster, or maybe they will be used with some antibiotic therapy. But we want to do things taking advantage of the science and not just more empiric treatment. So obviously none of this could get done without people other than me. And I do want to end on, I never give a talk and don't obviously give credit. So this was me shortly after learning that there was a heart available. Obviously I'm in the ICU. This was outside our back door the day I got home from the transplant, just reminding me that miracles do happen. So Tammy, I'm heartened that you read the book in 3 hours. It took me 15 years to write it because there was no good ending until the transplant. So I couldn't end a book saying I have 10% ejection fraction. I'm kind of hanging in there. I don't think anyone would have appreciated that ending. So when I had the transplant, I thought, wow, this is the ending. But then I thought, I got to be running again. I can't just end it on the transplant because, as you'll read, the transplant afterwards was not just a straight shot. And so I waited until, I don't run marathons anymore because my wife told me I've had my one replacement part for my life. So I just do half marathons now. And this was my first half marathon in Washington. And it's kind of, I always wear my heart transplant at Duke. It pisses the people off running behind me. I heard them all the way like, we cannot let that guy beat us to the finish line. So I always tell people, if you can and you don't have it on your license to be an organ, because certainly I wouldn't be here today if it wasn't for somebody. I'll just tell you this very briefly, that after the race, this young woman came up to me and she said, you know, you're a real inspiration, because again, I'm wearing my shirt. And I said, oh, thank you. And she said, I was using you to pace me for the first 10 miles. I'm like, yeah, you know, you look like you're about 21. So that's a good thing. And then she told me that she was a nurse in the heart transplant unit at Duke, and so she was really inspired to be following my chart as she was running. So anyway, I thank you for your time, and I'm happy to entertain questions.